Welcome back. Now we're going to do a quick talk on inopressors. This includes dopamine, epinephrine, and norepinephrine. I'm going to be brief with this content since we'll spend considerable amount of time discussing both norepi and epi when we move into specific treatments for various shock classes. Dopamine has limited use, so we'll be brief with that discussion as well. We're chatting about inopressors. Ino meaning contractility, in this case, increased contractility. Pressor meaning constriction. So these medications increase SVR and blood pressure while increasing contractility and in general increasing heart rate. First up is dopamine. Now dopamine's actions are mediated by several types of receptors. While there's a great deal of individual patient variability, generally we look at dopamine in dosing groups of 0 to 5 mics per kilo per minute, 5 to 10 mics per kilo per minute, and lastly 10 to 20 mics per kilo per minute. So doses at 0 to 5 mics per kilo per minute affect mainly the dopaminergic receptors. This causes renal vasodilatation and increases natriuresis and diuresis. And while this sounds great, it doesn't improve peak creatinine levels, requirement for renal replacement therapy, or affect ICU or hospital length of stay. In addition, it causes more pro-arrhythmic events. We used to refer to this as renal dose dopamine. So just to be clear, renal dose dopamine has been proven not to work, to be ineffective. Then we move on to doses of 5 to 10 mics per kilo per minute, and this agonizes the beta-1 receptor. This results in positive inotropy and positive chronotropy. And then last but not least, doses between 10 to 20 mics per kilo per minute affect the alpha receptor, resulting in vasoconstriction. Now if you think about it, dopamine's a precursor to norepinephrine. When comparing the use of the two drugs, norepi is just plain out more potent than dopamine when it comes to vasoconstrictive properties. In addition, there's more pro-arrhythmic events with the use of dopamine compared to norepinephrine. There's also some signal in literature that dopamine may increase mortality in cardiogenic and septic shock. So when should and when shouldn't we use dopamine? So first, don't use dopamine as renal dose dopamine. And then next, it doesn't make sense to use dopamine for its vasoconstrictive properties. Just use norepinephrine instead. So as a generalization, the ideal use for dopamine is during a bradycardic shock type picture. Next up is the infamous norepinephrine. It exerts its effects via beta-1 and alpha receptors. It's a potent vasoconstrictor with some moderate inotropic effect. If you think about it, it increases the SVR, the blood pressure, the LV afterload, the cardiac filling pressure, contractility, stroke volume, and coronary blood flow. Interestingly, its chronotropic effect is minimal compared to other catecholamines, and this is due to the barrel reflex stimulation due to the drug's potent vasoconstrictive properties. And as alluded to in the previous slide, when it comes to the vasoconstrictive properties, norepinephrine is stronger than dopamine. And as most of us probably are already aware, norepinephrine is the preferred first-line agent for septic and cardiogenic shock. We'll wrap up this brief chat with epinephrine. It's the final end product of the endogenous catecholamine pathway. It's the top dog. It possesses very potent beta-1 and alpha actions, and this results in intense vasoconstriction and aggressive positive inotropic and chronotropic effects. Interestingly, at low doses, epinephrine surprisingly agonizes the beta-2 receptor, so it actually has vasodilatory effects. The way that I see it in my mind is that at lower doses, you'll see the beta-2 dilatory effects, but those actions are quickly overcome as the dose goes up and the alpha stimulation becomes more prominent. The drug as a generalization causes an increase in SVR, contractility, blood pressure, and coronary blood flow. And this all sounds excellent until we review some of the side effects. The most worrisome adverse effects are tachydysrhythmias, hyperglycemia, lactic acidosis, more specifically type B lactic acidosis, and then lastly, catecholamine toxicity, and this is a form of cardiac myocyte apoptosis, more simply said, cardiac muscle death. This wraps up our brief talk on inopressors. Next up, inodilators.